In this presentation, I am going to talk about hypertension, specifically or more focused on hypertensive crisis. If you remember from last spring, this is actually one of your lectures. So you probably already have your basic concepts of hypertension. However, I believe that, and I'm pretty sure some of you still need a recap or review of the concepts of hypertension. So, what you will notice and on the next few, well, most of the slides after this will be doing a recap of hypertension, the definition of hypertension. I'll be talking about classification of hypertension, the pathophysiology, or the risk factors, clinical manifestations, the complications of hypertension, what are the and diagnostic tests for hypertension, what are the treatments. I'll also be talking or giving you a video of the renin, angiotensin, and aldosterone system, which is really important to understand your blood pressure medications and finally I'm going to have a recap or review of your antihypertensive medications. So here's the thing: if you think that you already know all these things, then you can go ahead and jump into my last, probably not last 2 to 3 slides, that starts with, or that would start with, hypertensive crisis. Okay. However, for the purpose of examination, materials will be taken mostly from the concepts on hypertensive crisis, because that's what we're going to be focusing here in Nursing 3. As I mentioned, you already have your concepts from Nursing 2. But then again, I may be having, or I may be getting few points or few items from other concepts of hypertension, specifically your hypertensive medications. So, um, this assessment and management of patients with hypertension is found in your Brunner book, 14th edition, pages 884 to 898. So we will start this presentation with understanding blood pressure. So you will have 2 videos. You will watch 2 videos. Again, if you feel like you already know it, you can always skip the video, right? That's the beauty of the voice thread. So first video shows you a really good animation of blood pressure, same as the second one. The second one then shows you how it complicates, or how hypertension complicates to atherosclerosis and stuff like that. You can still want to watch. You may want to watch that as well, because that's important to understand your acute coronary syndrome, which would be your next cardiac lecture. So either way, it doesn't hurt to watch it. So again, I repeat, the next few slides are review. The hypertensive crisis are, or is, the focus for your Nursing 3 lecture.
Let's look at the concept of blood pressure. Let's start by examining where the pressure in blood pressure comes from. Each time the heart beats, blood gets pushed out of the heart and into the arteries. The blood is like the freight train of the body and carries essential nutrients and oxygen to all of the cells. So it has to be pushed out of the left ventricle of the heart with enough force behind it for these nutrients to reach every single cell of the body. This force also has to keep the blood moving at a certain speed throughout the body, because if it moves too slowly or pools, it's in danger of clotting. Blood leaves the left ventricle under relatively high pressure of about 100 to 140 millimeters of mercury. How much pressure is that? It's about as much pressure as it takes to squeeze a tennis ball quite hard in your hand. Try doing this 1 time a second and you'll soon get an idea of how hard the muscles of your heart are working. With each beat, the blood that gets pushed out into the arteries presses against the walls of these arteries. And this is the pressure that's measured when your blood pressure is checked. Now, these walls are normally quite elastic and flexible and allow the blood to flow with little resistance. However, if these arteries become stiff and narrowed, by plaque or other fatty substances, they become diseased. And the heart has to work harder with every beat to get enough blood through these narrowed, diseased vessels. This increased workload on the heart results in an increase in the pressure on these arterial walls and therefore an increase in the blood pressure. Imagine water running through this hose is the blood running through your artery. A blockage in the hose means the faucet has to be turned up to get the same amount of water to flow through it. It's just like your heart having to work harder to get the blood through the blocked artery. So, when your blood pressure is measured, it's essentially an indicator of how hard your heart has to work to pump enough blood with every beat. Because high blood pressure has no symptoms, many people do not know they have it. This is why high blood pressure is often called the silent killer. The only way to tell if you have high blood pressure is to have your blood pressure checked regularly. So remember, the higher your blood pressure, the harder your heart has to work with each beat.
If you lined up all the blood vessels in your body, they'd be 95,000 kilometers long. And every day, they carry the equivalent of over 7,500 liters of blood, though that's actually the same 4 or 5 liters recycled over and over, delivering oxygen and precious nutrients like glucose and amino acids to the body's tissues. All that blood exerts a force on the muscular walls of the blood vessels. That force is called blood pressure, and it rises and falls with the phases of the heartbeat. It's highest during systole, when the heart contracts to force blood through the arteries. This is your systolic blood pressure. When the heart is at rest between beats, blood pressure falls to its lowest value, the diastolic pressure. A typical healthy individual produces a systolic pressure between 90 and 120 millimeters of mercury, and diastolic pressure between 60 and 80. Taken together, a normal reading is a bit less than 120/80. The blood traverses the landscape of the body through the pipes of the circulatory system. In any plumbing system, several things can increase the force on the walls of the pipes: the properties of the fluid, extra fluid, or narrower pipes. So if the blood thickens, a higher pressure is needed to push it, so the heart will pump harder. A high salt diet will lead to a similar result. The salt promotes water retention, and the extra fluid increases the blood volume and blood pressure. And stress, like the fight or flight response, releases hormones like epinephrine and norepinephrine that constrict key vessels, increasing the resistance to flow and raising the pressure upstream. Blood vessels can usually handle these fluctuations easily. Elastic fibers embedded in their walls make them resilient. But if your blood pressure regularly rises above about 140/90, what we call hypertension, and stays there, it can cause serious problems. That's because the extra strain on the arterial wall can produce small tears. When the injured tissue swells up, substances that respond to the inflammation, like white blood cells, collect around the tears. Fat and cholesterol floating in the blood latch on too, eventually building up to form a plaque that stiffens and thickens the inner arterial wall. This condition is called atherosclerosis, and it can have dangerous consequences. If the plaque ruptures, a blood clot forms on top of the tear, clogging the already narrowed pipe. If the clot is big enough, it can completely block the flow of oxygen and nutrients to cells downstream. In vessels that feed the heart, that will cause a heart attack when oxygen-deprived cardiac muscle cells start to die. If the clot cuts off blood flow to the brain, it causes a stroke. Dangerously clogged blood vessels can be widened by a procedure called an angioplasty. There, doctors thread a wire through the vessel to the obstructed site, and then pass a deflated balloon catheter over the wire. When the balloon is inflated, it forces the passageway open again. Sometimes a rigid tube called a stent is placed in the vessel to help hold it open, letting the blood flow freely to replenish the oxygen-starved cells downstream. Staying flexible under pressure is a tough job for arteries. The fluid they pump is composed of substances that can get sticky and clog them. And your typical healthy heart beats about 70 times a minute, and at least 2.5 billion times during an average lifetime. That may sound like an insurmountable amount of pressure, but don't worry. Your arteries are well suited for the challenge.
Okay, so hypertension or high blood pressure is the most common chronic disease among adults in the United States and in the world, and it has been identified as the leading risk factor for premature death, disability, and overall disease burden worldwide because it may lead to cardiovascular disease, stroke, and chronic kidney diseases when not appropriately treated. So it's therefore important for us to know specific or to how to appropriately assess, monitor, educate, and intervene patients with hypertension. So, with the new updates with or defined by the American College of Cardiology or ACC and the American Heart Association or AHA, with our new update with the book as well, they have defined blood pressure or I'm sorry, hypertension with a systolic blood pressure of 130 millimeter mercury or higher and a diastolic blood pressure of 80 millimeter mercury and higher. Now, this classification system for hypertension has been further revised by the ACC or the AHA, as I mentioned. They want to include elevated stage one, stage two categories as displayed in this slide. Um, they want to emphasize the direct relationship between the systolic blood pressure and the diastolic blood pressure, the risk of morbidity and all cause mortality, and specifically the cardiovascular mortality. We used to call uh, the blood pressure of 120, systolic blood pressure of 120 to 129 as pre-hypertension category, but they switched it to an elevated blood pressure category. Okay, the rationale for this change of terminology is to highlight the association between any elevated blood pressure and increased cardiovascular risk. So go ahead. You can see the slide in here. Normal blood pressure now is less than 120 systolic and diastolic less than 80. Now you consider elevated blood pressure 120 to 129 systolic, diastolic of less than 80 still. Now we consider stage one with a systolic blood pressure of 139, 130 to 139 and diastolic of 80 to 89 and the stage 2 hypertension of more than 140 to 159 with a diastolic of more than 90 millimeter mercury. So the thing here is like I keep on mentioning, you have reviewed this in spring. Okay, it's just important to know the different category. I am more focused with the hypertensive crisis on the bottom or the last few slides of this presentation. So this is more of a recap for you. So again, why do we call hypertension as a silent killer or the silent killer? Because a lot of times patients or people do not know that they have high blood pressure or hypertension because they have no obvious symptoms. They do not know, they do not have any symptoms. And the thing is, if you are symptomless, okay, or asymptomatic to be more medical here, high blood pressure will put you at risk for a lot of serious life-threatening health problems. And now, what are two categories of hypertension? We do have essential and the secondary. Essential, or also called the primary hypertension, happens to 90 to 95% of patients. And as I mentioned, there is no cause for this. It's called unidentifiable cause. Secondary hypertension happens to 5 to 10% of patients. And a lot of times we do have the secondary hypertension has underlying causes of reason, or a lot of causes for this. The book shows you different kinds or common causes of secondary hypertension, among which are your renal diseases, your sleep apnea, pregnancy related, renal artery stenosis, and so on and so forth. Okay. About 33% of the adult population of the United States has hypertension, and again, 46% of them do not have it under control. It's high, and it's prevalent in African American population. All right, I'm going to be very detailed with this slide because I feel like it's really important to know risk factors, even if you think you already know it. Um, So let's proceed. We do have modifiable and non-modifiable risk factors. And we say modifiable, these are things that can be changed, and non-modifiable, things that we can't change, among which are, for non-modifiable, we have your age, gender, ethnicity, and family history, and the rest of the bullets are modifiable factors. Um, so let's begin with your new book. We have the age as more than 75 years of age and older. And for the gender, it affects 80% of men and 85.6% of women. Okay. More female than males. Um, we do have ethnicity African American, as I mentioned earlier, that they are more prone or at high risk. Also, some of the Caucasian females, or Caucasian Mexican American can have uncontrolled hypertension. I'm so sorry. Any family history, anything by blood, can be at risk for hypertension as well. Okay, so moving on, let's talk more about the modifiable factors. So alcohol, what does it do to you? Well, obviously, drinking too much alcohol can raise your blood pressure to unhealthy levels. More than 3 drinks, okay, or 2 drinks now with the book, 2 drinks per day for men, and more than 1 drink per day for women can raise your blood pressure. And repeated binge drinking can lead to long term disability. There's a lot of possible mechanisms for this. There's one because of the imbalance of the central nervous system. It could be because of the impairment of the baroreceptors. There's an enhanced sympathetic activity and stimulation of the renin-angiotensin, aldosterone system, and increased cortisol levels, increased vascular reactivity due to increased intracellular calcium levels, stimulation of the endothelium to release vasoconstrictors, and loss of relaxation due to inflammation and oxidative injury of the endothelium, leading to inhibition of endothelium dependent nitric oxide production. Yes, I know that's a lot of words. Basically, it's pretty much the same thing with having a tobacco. It has something to do with how this hypertension and how alcohol can cause vasoconstriction. Tobacco. So, yes, I know smokeless, and not I know, but you should know by now that smokeless tobacco consistently produces levels of nicotine higher than those seen with smoking, and causes similar sympathetic neural stimulation and acute cardiovascular effects. Have you thought about the reason why cigarette smoking can actually damage your heart? Like, what is it? What chemicals do they have? Yep. For those who know it, you're right. It's nicotine and carbon monoxide. So they do interfere with your or with the cardiovascular system's ability to function properly. So any exposure to nicotine and carbon monoxide can change the heart and blood vessels in many ways and can increase the risk for heart and cardiovascular disease. Nicotine, particularly, what would it do? It will cause vasoconstriction, so it causes your blood vessels to constrict or narrow, and it limits that amount of blood that flows to vital organs. And in time, constant constriction will result to blood vessels that are stiff and less elastic. If there's constricted blood vessels, what happens is there will be a decrease in the amount of oxygen and nutrients to the cells, that the cells would receive, and they would need for more oxygen, and the heart rate will increase. Again, you're tiring the heart. Carbon monoxide, on the other hand, will bind. Okay, the carbon monoxide binds to hemoglobin, and it's the molecule in that blood that carries oxygen. Hemoglobin. When carbon monoxide is bound to hemoglobin, oxygen cannot bind. Okay, now it will decrease the amount of oxygen delivered to all cells, and to provide the body with more oxygen. Um, the heart may enlarge because it will have to contract more so it can pump more blood around the body. So basically, nicotine and carbon monoxide due to cigarette smoking can cause hypertension and any kind of cardiovascular diseases. Now, diabetes. Okay, what's up with this? So again, you've learned diabetes. I'm not going to go through this, but your body makes insulin. Insulin causes your body to retain salt and fluids, and which is one way, diabetes increases your risk for high blood pressure. Right? Now, lipids or lipids, however you say that, high cholesterol levels can significantly cause higher blood pressure during exercise than those with lower cholesterol levels, by the way. It's another fun fact here. We're going to talk more about atherosclerosis on our next lecture. So, but basically, high cholesterol levels can cause um, problem eventually and will result to increase high blood pressure. Dietary sodium. So what does it do? Okay, sodium, again, when there's sodium, there's water, okay? When there's sodium in the bloodstream, it pulls water into the blood vessels and increases the total amount of volume of blood inside them. So with more blood flowing through the blood vessel, blood pressure increases. And again, just like what you've watched um, earlier or in the videos on the first few slides, the water supply to a garden hose, the pressure in that hose increases as more water is blasted through it. So again, over time, high blood pressure may overstretch or injure the blood vessel walls and speed the buildup of gunky plaque that can block through the blood flow. And the added pressure tires out the heart by forcing it to work harder to pump blood through the body. And the extra water in your body can lead to bloating and weight gain. Obesity, um, again, having excess weight can cause blood pressure to increase since there is more blood flowing through that blood vessel and arteries. You can expect more pressure inside. What else? Sedentary lifestyle. Okay. What else we have here? A sedentary lifestyle. Yes. A sedentary lifestyle is a major risk factor for heart and blood vessel disease. I mean, people who are less active and less physically fit have 30 to 50% greater chance of getting high blood pressure than their more active peers. And having a sedentary lifestyle can raise your risk of premature death. So, obviously, the more sedentary you are, the higher your health risks are. Socioeconomic lifestyle. Socioeconomic disparities in the prevalence of hypertension have long been observed in high income countries where sound epidemiological evidence associates high socioeconomic status with a lower prevalence of high blood pressure and cardiovascular disease. And an association is consistent across a variety of indicators of social position. Stress. Stress can also cause hypertension, again, through repeated blood pressure elevations, as well as the stimulation of the nervous system to produce large amounts of vasoconstricting hormones that increase blood pressure. So, a lot of factors that affect blood pressure through stress would be what? Your white coat, hypertension, your job strain, the race, the social environment, and emotional distress. Those are things. Okay, nursing school is a very stressful job. Okay. Furthermore, one risk factor is coupled with over stress producing factors. The effect on blood pressure is multiplied. Overall, studies show that stress does not directly cause hypertension, but can have an effect on its development. So, these are just some of the things or some of the risk factors that we have. Um, and in your book, we also have sleep apnea as the last risk factor. Okay, guys, so super important with clinical manifestations is that many times people or patients are asymptomatic. Okay, asymptomatic from the root word symptom. A means absence of symptoms. Okay, they don't know. So yeah, the biggest issue with that is, it says right in your book, page 885, that hypertension is called the silent killer because people are often symptom free, okay, and they don't know they have it, and they don't have any idea until it's too late, until they have some kind of a complication of hypertension that they're even experiencing it. So obviously physical examination findings would be, you know um, an elevated blood pressure when they have, they may have nothing other than that, and you see some retinal changes as well. Some of them like hemorrhages, which is, or the accumulation of fluid, which is exudates, arterial narrowing, some small infarction. So you will also see some like reddened areas around the sclera. So when you're looking, you want to make sure that, you check, or when you're checking your patient, you want to see the eyes as well. It's really important. um, some patients are obviously, at risk for cardiac diseases, and actually some most of the time these patients these patients will have symptoms of coronary artery disease and potentially even have a myocardial infarction in them, and it may be a sign, the first sign or symptom of hypertension that they have, and they may have never known they had it. So it's really important that, you know your risk factors, you know your causes. Okay, if you're at risk, then you want to make sure that, you kind of like check your blood pressure once in a while if you have a very very stressful life, because the scary thing, like I mentioned, it's a silent killer, and you can go on for years without having any symptoms, and then it's going to be too late that, hypertension has already occurred, some target organ damage. So those are for clinical manifestations. So complications, obviously, of hypertension. We just talk about coronary artery disease. Coronary artery disease. There's a plaque buildup in surrounding the vessels, and it could cause hypertension. Angina and MI. Person may have hypertension for years, not know that they have it in the first finding, and maybe when they develop angina and chest pain, and come to find out that they have hypertension, it happens. So they're hypertension may be a secondary diagnosis for now. All of a sudden, not only do they have hypertension, but they have coronary artery disease, or maybe angina, or they'll find out that they also have an MI. So those are things that's really important. Left ventricular hypertrophy. So your ventricles are, or, you have four chambers of the heart. Ventricles is a big, this is the fattiest muscle, or that's, yeah, the big muscle. So it's a muscle, and it grows, so every time you use it, it grows in size. So what happens is, if there's an increased workload of the heart because a patient has an hypertension, it could cause left ventricular hypertrophy, and it's not going to go back, it's going to be more stiff. So that's another issue, and if that happens, um if there's left ventricular hypertrophy, sometimes heart failure follows, and heart failure is bad. Okay. And the other organ damage would be, as I mentioned earlier, your renal changes, or I'm sorry, the retinal hemorrhages, specifically organ damage like your kidneys. Okay. Kidneys will have renal insufficiency, and it could cause to chronic kidney disease, or CKD. So it's important for you guys to, when you check your labs, you want to make sure, um, check for any increased BUN, or blood urea nitrogen, and serum creatinine levels. These patients may have nocturia, they pee at night. So those things that you need to watch out for, any kind of kidney damage. CVA, or cerebrovascular accident, it's called stroke, also known as stroke. And TIA. TIA is transient ischemic attack. also known as mini stroke. So these are also complications of hypertension. Just so you know, cerebral infarctions account for most of the strokes in patients. Cerebral infarction, I mean, there's a big clot in the brain, and usually it's caused by hypertension. Also, bleeding in the brain is caused by uncontrolled hypertension. There's tons of things going on. It only affects your eyes, it affects your kidneys, it affects obviously your heart. It would affect your brain as well. And another thing that hypertension targets would be the peripheral arterial disease. So um, the peripheral vessels are also affected. It can cause aneurysm, outpouching of the blood vessels, which is bad, especially if it's a cerebral aneurysm. It can be a triple A. Have you heard about that? Abdominal aortic aneurysm can be a TAA, thoracic aneurysm. And it could cause aortic dissection, kind of like dissects and about to pop out, especially if it ruptures. So those are things that you have to watch out for. So it's really important to, screen your blood pressure. Okay, it's important to definitely capture this in the very early stage, so we can provide teaching, we can do modifications, lifestyle modifications, and obviously you want to avoid these complications because these are complications that you really don't want to have if you have hypertension, and hopefully to minimize and prevent that. There are no laboratory tests exist to diagnose hypertension. However, there are several laboratory tests that you can identify. So you can identify the cause of a secondary hypertension and target organ damage. So we would want to start with your analysis. You want to make sure that you see if the patient has protein or sugar content in the urine. You may also want to be looking at their BMP and CMP. BMP means basal um, metabolic basic, I should say, basic metabolic pattern and panel, and CMP, comprehensive metabolic panel. So what we check here would be their electrolytes, sodium, potassium. Those are the most specifics. You also want to check their BUN and creates part of the BMP. These are your renal function examination or tests. So you want to make sure that they have good kidney function. You want to look into their cholesterol levels, their HDLs, the LDLs. These are your lipoproteins. So HDL, you want that lipid high. These are the good cholesterol, and LDLs. These are your bad cholesterol. So you want their cholesterol levels, and as I mentioned earlier, you want that less than 200. These are your cholesterol panels, and your triglycerides. These are our trigs. Next thing here, we have the fasting glucose. Again, should check for any diabetes. You want to check for A1C or hemoglobin A1C. This shows how much, your sugar for the past 3 months. Um, 12 lead ECG. So again, if patient doesn't have any chest pain because they're asymptomatic, we just want to make sure we have a baseline, and we want to know were there any baseline when they are diagnosed with hypertension, because as we said, they can be at risk for further complications down the road. And we want to make sure that the baseline, we want to know what their baseline is, and hopefully by treating that, we would prevent the complications. Echocardiogram. We may want to offer echocardiogram to these patients because you want to look at the left ventricle. Remember, one of the complications is left ventricle hypertrophy. You want to see the function of the left ventricle. We want to see the heart valves, how they're functioning, how they're pumping in, and you make sure everything is okay. There's no any clot, no valvular issue. There's no heart failure. 24-hour urine to check for urine protein. Again, we can do that too as part of the laboratory tests. So additional studies would be your diagnostic. So as I mentioned, we can check for creatinine clearance. Um, we want to make sure your book doesn't say it, but ATI book would say elevated serum corticoids. You want to check for Cushing's disease, so you'll learn more about that. So these are your laboratory tests, and obviously, the diagnostic, aside from their ECG and echo or echocardiogram, you definitely want to check for X-ray, chest X-ray, so it would show cardiomegaly or enlargement of the heart. Health history. So, second assessment that you want to do is you want to make sure, and again, health for health history is actually one of your way of detecting for any modifiable or non-modifiable risk factors. So, you want to know about their family history. You want to know about their social history. Do they smoke? Okay. What is their social atmosphere? What is like in their home? Like, um, do they have a stress level? Do you want to know if they have any childhood illnesses? They might have like scarlet fever in the past or any group A. They have strep throat for 5 times in a year. So those guys. Um, you want to know if for the PE, obviously you want to do your cardiovascular assessment. You've been doing that. You've been doing your nursing process form, so you want to listen to the heart sounds. Does the patient have any murmur? So is it regular? Is it irregular? Okay, you want to see the heart monitor. Is there any dysrhythmia? um, you want to check on the presence of edema. Does a patient have any edema? Any edema would mean something, a lot of issues. So that means that patient might have heart failure as well. You want to check on their pulses. Are they equal? Are they regular? Okay, are they strong or are they weak down there? Or one arm is weaker, one arm is stronger. So things like that. I also mentioned about retinal hemorrhage as part of the complication. So obviously, you want to make sure that um, you check on their retina. That would be their first. The one of the most important things that you need to check will be check on their eyes. You check the sclera. Make sure there's no any abnormalities, no bleeding, any kind of infection in there. So, yeah, physical exam, health history. The most important thing here is the risk factor. So, again, we've asked about how much they're smoking, how many pack per day, how long have been taking, you know, how long have they been smoking, um, how long was the duration, and how much. Okay. Also, smoking, I'm sorry, alcohol intake. So how much alcohol and how long have you been drinking? So things like that. So it's what else? Risk factors. So smoking, alcohol, the stress level. I've said that many times now. You might want to know about their sodium intake. Okay, because if you want to do a dietary recall on how much they eat or how much they eat their sodium, how much fatty food they're going, McDonald's or wherever. You want to do some medication on sodium intake as well, and talk about fats and cholesterol. So all of that kind of stuff to get them to understand the importance of all these potential modifiable risk factors to help with the treatment of their hypertension. The most important thing in the first step of diagnosing hypertension is the accurate blood pressure measurement. Remember, an average of at least two blood pressure readings on at least two occasions will confirm the diagnosis of hypertension for most patients. Now, there's what we call a whole blood pressure measurement or HBPM or ambulatory blood pressure measurements. These are considered more accurate reflections of their blood pressure status. They are not only used to confirm the diagnosis of hypertension in most cases, but also they evaluate whether success has been achieved with treatments such as lifestyle modifications and prescription medications. Um, there are also alternative manifestations for patients. Patients with masked hypertension, they exhibit elevated blood pressure at levels typically consistent with hypertension in settings outside the hospital or clinic, while their blood pressure is seemingly normal in healthcare settings. And in contrast, the patients with white coat hypertension, they have blood pressure readings that would suggest a diagnosis of hypertension when they are in healthcare setting or clinics, but are within the normal ranges in other settings. So what does this tell you? If untreated, the patient with the masked hypertension can go on to experience adverse cardiovascular events such as MIs or myocardial infarction and strokes and mortality. And on the other hand, the patient with white coat hypertension may receive treatment that is not warranted. Okay, so as I remember telling you, the target organ for hypertension are the brain, the eyes, the heart, the kidneys, and also the blood. Um, there are also abnormal findings from the physical examination that could suggest target organ damage due to hypertension. So one is your peripheral pulses. They can be absent and weak, and we could have delayed femoral pulses. Again, this could suggest coarctation of the aorta. What is that? You learn more about that in nursing four, or it can be because of a severe peripheral vascular disease. Next is the neck. Should also be examined for corroded bruit, distended veins, and enlarged thyroid gland. The upper abdomen can also be auscultated for the presence of a renal artery bruit that could be suggestive of renal artery stenosis. Then again, I've mentioned again and again the signs of left ventricular hypertrophy. This is seen by the displacement of the apex. Um, and there's a sustained and enlarged apical impulse in the presence of an S4 cardiac sound. Occasionally, signs of hypertension can be discovered during a fundoscopic eye examination manifested as we call a hypertensive retinopathy, where you will find retinal hemorrhages, those papilledema, things that I've mentioned earlier. Um, Acute or chronic ocular changes can be initial finding in asymptomatic patients and typically require a referral to an ophthalmologist. Long-standing untreated hypertension can cause heart failure, CKD, or chronic kidney disease by checking on your elevated BUN and creatinine, and increased risk of CVA, TIA, or strokes. CVA, yep. Um, I did mention about the laboratory tests earlier. Um, if you can also see in this picture, some of them, pretty much what I mentioned earlier, the high blood pressure or headache, or the headache is one of the hypertension symptoms that may occur in hypertensive patients. But remember, they are most asymptomatic. But however, they are mostly typically they happen in early morning in the occipital region, and they're throbbing. Again, it has something to do with it's because of your high blood pressure. Sometimes, though, a patient can have dyspnea and exertion. This because of an increased level of activity or physical activity. This patient with hypertension can complain of tightness in the chest. Chest pain can also happen due to some issues with the myocardial ischemia. Um, You may also have hematuria aside from the nocturia, peeing at night, or oliguria, less pee or less urine, less than 30 mLs per hour urine. Or you could also have hematuria, which is presence of blood in the urine. This can only be seen microscopically, and it can be a secondary cause of your hypertension, possibly targeting your target kidneys, your kidney organs. So these are just some of the few physical examination for patients with hypertension. Now, the goal of hypertension treatment is to prevent complications, meaning that reaching the target organ or damage to your target organs, like I mentioned. You want to maintain a blood pressure lower than 130/80. And per the guidelines by ACC and AHA, they developed a series of recommendations to prevent and to treat and manage hypertension. A patient without a prior diagnosis of hypertension with an elevated blood pressure, meaning systolic blood pressure of 120 to 129 and diastolic of 80, less than 80, should be advised to follow up with additional blood pressure readings within 3 to 6 months. A patient with blood pressure that's been consistent with hypertension, that is systolic blood pressure greater than 130 and diastolic of more than 80, should follow up with additional blood pressure readings within 1 month's time to either confirm or rule out the diagnosis. Any blood pressure readings greater than 160 over 100, on one occasion these patients are diagnosed with hypertension right away, and there should be they should begin the treatment with antihypertensive medications. So all patients who report lifestyle choices that may put them at risk for hypertension should be counseled to adopt lifestyle changes as appropriate. Lifestyle changes, I'm sorry, should include weight loss, dietary changes, modifications, physical activity modifications, I should say, decreased alcohol consumptions and smoking cessation. Your book in Hinkle, page 871, table 27-2, shows you the lifestyle modifications to prevent and manage hypertension. Um, in addition to this, we also have a particular DASH diet, or called the dietary approach to stop hypertension diet, and it has been the most effective diet in decreasing blood pressure, I should say. If it's used in conjunction with weight loss, this diet can lower systolic blood pressure by 11 to 16 millimeter mercury. That's a lot. In addition to this dietary advice, patients should be counseled to incorporate a low sodium diet, which is less than 2 grams per day, and high potassium diet of 3,500 to 500 or 3,500 or 1,500 milligram per day diet. This dietary combination is more effective than following either a low sodium or high potassium diet. A high potassium diet must be avoided in patients with CKD. Just just to remember that, for you to remember that. The recommended treatment for patients with elevated blood pressure but who are not diagnosed with hypertension is lifestyle changes, not antihypertensive medications, with follow-up in 3 to 6 months, as I noted earlier. um, Again, you can see the DASH diet in page 871, table 27-3, and lifestyle modifications in at the same page. Aside from those things mentioned, I also mentioned here biofeedback, relaxation, meditation as also part of your treatments. Now we're going to talk about medical management for hypertension. Our pharmacological agents, as seen in this picture, the purpose of administering this medication is to prevent or to reduce the risk of cardiovascular disease, cerebrovascular diseases, and death. And there are classifications of medications available for hypertension management. These are found in your book, page 872, and tables 27-4 and 27-4, oral medications for hypertension, and 27-5, oral medications for patients with comorbidities and those patients who are pregnant. So with the medications that have been shown to prevent CVD, they are recommending, or the AHA, ACC, they are recommending the first line of agents for most patients, and among which are your AB. I call this A, B, C, and D. Okay, A as that stands for ACE inhibitors and your angiotensin receptor blockers. We have the B's, we have the beta blockers, and C, calcium channel blockers. And again, these are not new to you because you have learned this. But just a recap: when you think about ACEs, think about the word PRIL. Okay, PRILs. That's why in this picture it says it ends in PRIL. So these are your A PRIL meds, your Capitan or Captopril, enalapril or Vasotec, and you also have your Benzapril, low tensin, and there's more to that. Now we're gonna talk about the beta blockers in the next few slides, but I'm sure pretty everybody knows what beta blockers are. This ends in the OLOL, OLOL. Okay, and these are propranolol, atenolol, nadolol, and so on and so forth. We also have the next under C, or calcium antagonists. Okay, These are your calcium channel blockers. So I call this very nice drugs. The V, N, and D. These are the most common calcium antagonists or calcium channel blockers. V as to verapamil or your Kalen. D as to your diltiazem or cardizem, and verapamil, I'm sorry, Kalen, N as in your nifedipine or procardia, and D as to diltiazem or cardizem. These are all calcium channel blockers. And then the letter D is your diuretic. So we have a lot of diuretics that you guys know. You have your loop diuretic, you have your potassium sparing, and we do have the thiazide diuretics. But for the purpose of knowing these medications, these are all found. Certain medications are found in your table on the pages I mentioned earlier. So anyway, for the first line, okay, remember the first line of medication for African American patients with hypertension without heart failure or CKD, they are given the thiazide diuretic or the calcium channel blocker. Okay, these are your first line agents. The recommended first line for antihypertensive medications for patients with comorbidity are displayed in 27-5. Remember, your goal is to describe first low doses of medication. Okay, your goal is to lower the blood pressure less than 130/80, and the dose is increased gradually, and additional medications are included to achieve the control of the blood pressure. The simplest treatment schedule possible is ideal as it promotes adherence to that regimen. Let's say, for example, one pill each day or two or more agents combined into each pill. So our goal for hypertensive medications is for patients to be compliant. It's the compliance, it's the adherence to take their medications on a daily basis, or they should be religious in taking their medications. So before I actually proceed with giving you more details on the ABCD of hypertensive medications, I'd like you to watch on your next slide. We'll be watching the renin-angiotensin aldosterone system. If you already know this, then again you can move on to the next slide. But for those who forgot about this and needs a recap or review, then by all means watch the slide. It's gonna be helpful to understand all your different hypertensive medications, where do they act, and which part of the system. Okay, so enjoy.
Okay, so one of our Instagram friends requested a review video on the RAAS system, and that stands for the renin-angiotensin aldosterone system. So I'm going to make this very short and sweet because I think it's easiest described with pictures and just kind of getting to the point, because it's really easy to understand really when you have it at this level. First thing, I want to make sure that we understand what the RAAS system does. Like, why is it in place? What is it supposed to do? So essentially, in response to low blood pressure or in response to low serum sodium, this system can kick in to help compensate for that. And when I say serum sodium, remember, when there is low sodium, that means there is low fluid volume, right? Because where salt goes, water follows. So if we don't have a lot of salt, then we don't have a lot of fluid. You don't have a lot of fluid on board, then your blood pressure is going to be decreased. So that makes sense. Okay, so this system is in place essentially to regulate blood pressure by bringing it up. Okay, and it does that with this whole kind of process of conversion and reactions. So let's begin with first thing first. So our liver releases a hormone called angiotensinogen. Okay, now when we're talking about hormone being released, we mean in the blood. Now, so angiotensinogen is released, right? In response to that, the kidney is going to shoot out an enzyme called renin. Now, together, this enzyme renin and this hormone angiotensinogen, they react, and you're going to end up with angiotensin. Let me spell that right. Angiotensin 1. Okay. Now, when angiotensin 1 is trucking along in our bloodstream and gets to our lungs, in response to this circulating, is going to release ACE. Now, this should look familiar because this is the level where ACE inhibitors work. ACE is an angiotensin converting enzyme. So when people take ACE inhibitors, what it's doing is it's stopping this enzyme from being released, right? Because we know that the ultimate goal is to raise blood pressure. But if we don't have this ACE release at this point, if we actually stop the conversion at this point, then we're not going to get to our end product and we're not going to raise blood pressure. So this is how we can stabilize blood pressure. Okay. Now, as this is trucking along into our system, ACE and angiotensin 1 together are going to make angiotensin 2. Okay. Now, angiotensin 2 works on the level of our adrenal glands, and it also works on the level of our kidneys, and I'm going to talk about that in a minute. So essentially, angiotensin 2 is going to get to our adrenal glands, right? And it's going to create aldosterone. And this is our end product. Now, this whole system is really a twofold type of system. One, it's going to create aldosterone, and aldosterone itself is going to have some effects on the body. And two, remember I said angiotensin 2 actually works on the kidneys level as well. It's going to do something there as well. So first, let's focus on the aldosterone. So we know when aldosterone is created, aldosterone creation is actually going to help blood pressure regulation. And so how does that do that? Well, when we have aldosterone, we actually are increasing the reabsorption of sodium. So if we increase the reabsorption of sodium, that means that we are increasing the fluid that we have on board, which essentially is going to increase our blood pressure, right? So here's our first way that aldosterone is going to work on our body to increase blood pressure. Now, this number 2 that I have here is really a side note that we have to keep in mind when somebody is releasing aldosterone in the body, because we know that aldosterone decreases potassium because it's leaving through the urine. Okay, so this is a side note to keep in mind with that. So the first way is sodium levels are reabsorbed, they're increased, blood pressures increase. Now, remember I said that angiotensin 2 also works at the level of the kidneys? Well, it does. It actually is going to cause vasoconstriction. So vasoconstriction in the arterioles. And so vasoconstriction in the arterioles is going to increase the blood pressure, right? We know that the more narrow our arteries become, the more narrow our vessels become, the higher the blood pressure is going to be. So this is kind of our twofold way. So we have our vasoconstriction in our arterioles that increase our blood pressure, and we have the increased reabsorption of sodium that's going to increase our blood pressure. Okay? Short and sweet, the RAAS system. So let's go through that again. So first thing, let's make a color so we can look at it. Let's do red. Liver releases angiotensinogen, right? In response to that in our bloodstream, the kidney releases renin. Renin and angiotensinogen together make angiotensin 1. When that reaches our lungs are going to release ACE. ACE and angiotensin 1 make angiotensin 2. Angiotensin 2 is going to work at the level of the adrenal glands and the kidneys, right? When angiotensin 2 gets to the adrenal glands, it's going to make aldosterone. And aldosterone will increase our blood pressure because it increases sodium reabsorption, which is going to increase the amount of fluid that we have. But we got to keep in mind that aldosterone also depletes potassium. So we have to think about that from a nursing perspective as far as client care preventative measures. In addition to that aldosterone release, we know that angiotensin 2 at the level of the kidney is going to cause vasoconstriction in the arterioles, which will increase blood pressure as well. So there you have it, short and sweet, the RAAS system. If you have any questions, you know how to reach me on Instagram at TOOTRN, TOOT.
You have to remember two things about angiotensin inhibitors. Earlier, I mentioned the angiotensin converting enzyme inhibitors, which are the ACEs. These are medications that ends in pril. That's why we call it the april. So we have another type of angiotensin inhibitors, which are called the ARBs, or angiotensin receptor blockers. So these are two different kinds of angiotensin inhibitors that act differently. So as for the ACEs, or the angiotensin converting enzyme inhibitors, it basically acts in inhibiting the conversion of angiotensin 1 to angiotensin 2. So thereby what it does, it lowers the peripheral resistance, thereby decreasing the blood pressure. As you can see on your left side. Now the ARBs, on the other hand, they block the effects of angiotensin 2 at the receptor. So which means we're stopping or preventing the blood pressure from coming up. Um, Most commonly used ACEs, as I mentioned, the prils. Don't forget that the captopril, enalapril, lisinoprils. Those are the ACEs. The ARBs are the TANs: losartan, olmesartan, valsartan, telmisartan. So all the TANs. Basically, when you give these medications, it's an antihypertensive drug. So I think it's common sense to just check the blood pressure, and the most common side effect is hypotension. The right slide, or the right picture, shows orthostatic hypotension, wherein patient get dizzy from a sitting position or when they change position, and there's like drop of blood pressure 20 to 30 points, or 20 to 30 millimeter mercury per subbook. Um, these guys will decrease, or these drugs will decrease peripheral vascular resistance without any changes in the cardiac output, or rate, or contractility. So um, basically, just the blood pressure. Aside from dizziness, GI distress, headache, you would hear most of the patients say they will have cough. So it's a teach the patient to, for new patients diagnosed with hypertension, I it's just important to teach them to report cough, which is definitely an adverse effect of ACE. So they have to notify the provider for this adverse effect, so the medication can be discontinued due to its persistent nature. Also, at the same time, we want to make sure that these patients will excuse me, report for any swelling of the tissues in the throat, as more worsening condition of the cough, because that shows angioedema. Angioedema is a rare but potentially life-threatening complication of getting lisinopril. So obviously, what happens here is there will be swelling in the tissues of the throat that can progress to obviously life-threatening obstruction and airway. So you want to make sure you inform the patients about that. Another thing is, for ARBs, you want to make sure you monitor hyperkalemia and hyponatremia. So thing with this is, if you may end up switching ACEs to ARBs if they do have this side effects for cough. So although the good thing about ACEs and the ARBs, they do help with patients with with diabetes, as a prophylactic treatment for patients with diabetes. They want to make sure it doesn't cause nephropathy, or any kidney injury, I should say. It kind of we have studies that say giving these medications will improve ejection fraction for patients with heart failure, and increase the chance of survival for post MI, or post heart attack patients. Beta blockers is a part, or a type of a SNS inhibitor. SNS, like sympathetic nervous system inhibitors. So this SNS inhibitors can be, or they have two types. We have the beta adrenergic blockers. These are your medications that ends in olol. low press metoprolol, atenolol, propanolol. Those are the guys. So these are beta blockers. So what it does is um, it decreases the cardiac output and they block the release of renin. Subsequently, it decreases the vasoconstriction of the peripheral vasculature. So as you can see here, obviously what's going to happen, there will be an effect in the heart rate. It slows the heart rate and it lowers the blood pressure. So when the heart rate gets low, it will allow the left ventricle to fill completely and lower the heart workload. So primarily these are medications given to clients who actually have unstable angina or MI or cardiac arrest and heart failure. So since we do have side effect with on the heart rate and obviously blood pressure, so this you want to educate your patients about checking their apical pulse. It always goes um, you will always hear students saying they hear it in their NCLEX review or I'm not review or NCLEX examination. So yes, check the apical pulse for 1 full minute. Um, you may want to teach the client that these medications can cause fatigue, weakness, depression, and sexual dysfunction. So one more thing that you need to understand is these patients cannot stop the medications abruptly without informing their doctors. Okay, why is that? Because it would lead to rebound hypotension. That's the basic for not stopping it, stopping the medications. um, I mentioned about checking the heart rate again and again. Do not forget it. You will also have to inform elderly or high risk elderly patients for um, that these medications can decrease renal and liver function. So if they have renal insufficiency or any renal or kidney diseases, they might not be able to take these beta blockers. Aside from hypotension, more specifically hypotension. So you want to instruct your clients to take blood pressures in 3 positions and observe for hypotension. So yeah, those are your beta blockers as your letter B in your antihypertensive medications. We do have another type of SNS or sympathetic nervous system inhibitors. Um, Again, it doesn't affect with the blood pressure. These are your alpha or mixed alpha and beta blockers. Examples of these are the carvedilol and labetalol. So it pretty much the same thing. It acts both in the alpha and beta adrenergic receptors, thereby that would decrease your that would cause peripheral dilation and decreases peripheral vascular resistance. So those are the things that you have to know about the beta blockers. Don't forget the OLOLs, OLOL. So for calcium channel blockers, what these medications do is they increase sodium excretion and they can cause vasodilation by preventing the movement of extracellular calcium into the cells. So when these things happen, it would lead to vasodilation, thereby it lowers the blood pressure. So there are there's no easy way, like I mentioned earlier, to remember the medications for calcium, but you can think of very nice drugs. So V and D, very nice drugs. V for verapamil, so all medications that ends with mils, like verapamil. I guess that's the only one. And then we have the N, the nifedipine, and then we also have the D, which is the diltiazem. So these the most commonly used calcium channel blockers. So one thing you want to reconsider here again is you want to monitor the blood pressure and the pulse, and you have to watch out for orthostatic hypotension because hypotension is a common side effect or adverse effect. Um, things that you have to so things to remember is bradycardia, low blood pressure, headache. Another client education or things that you have to tell your patients would be it can cause constipation. So you might obviously want to encourage your patients to take foods that are high in fiber. Also, um, you want to obviously because it decreases the your heart rate, so it could cause bradycardia. You may want to teach your patient how to take their pulse, monitor for any irregularity or lower than the established rate, and they have to call the doctors. Another thing that you have to remember with calcium channel blockers is to instruct your client to avoid grape juice, because grapefruit juice will potentiate the medication's effects, thereby increases the hypotensive effects and increases the risk of the medication toxicity. So those are the things that you have to think of. Another thing is these medications are not recommended. They're contraindicated for patients with heart failure. So you want to make sure you check if the patients have heart failure and do not administer this drug. Do not discontinue suddenly, again, cause of rebound hypotension. And I mentioned earlier, again, report for irregular heartbeat. Depression can also be uh, a side effect. You want to make sure you just decrease the doses for patients with liver or kidney diseases. Watch out for headaches and monitor for electrolytes. So those are important stuff that you have to know about calcium channel blockers. As for our last medication therapy for hypertension, we have the letter D, which is the diuretics. So, what are diuretics? It promotes sodium and water excretion, and reduces plasma volume and reduce vascular response to catecholamines. So, to be more layman about that, what it does is it helps the lower blood pressure by promoting sodium excretion. Remember, when there's sodium, there's water, okay? So they tend to follow each other in the body. So if we're excluding the high levels of sodium, we're also going to excrete water that is going to decrease our total blood volume, and thereby, as a significant result will be a decrease in the blood pressure as well. So that's how these work. Um, Again, for the types of diuretics, we'll have the thiazide, example of which are the hydrochlorothiazide. So what it does is um, it works in the ascending tubule, and it inhibits water and sodium reabsorption, and it increases potassium excretion. So just like in any other kind of antihypertensive medications, you want to watch out for postural hypotension. Other side effects would be dry mouth, muscle aches, tachycardia. Patients will have problems with the GI, weakness, thirst. Uh, you will also see increased in calcium, increase in uric acid. So yes, be cautious with clients who have gout. Increase in lipids, glucose, creatinine, but decrease in potassium, mag, and sodium. So that those are the side effects of thiazides. Another type of diuretic is the loop diuretic. So what it does again, it works in the loop by reducing reabsorption of sodium chloride and water in the kidney. So loop starts with letter L. Commonly known medication is your Lasix-L. So loop L, Lasix-L. Generic name is furosemide. You also have bumetanide and the torsemide. So obviously, it's a loop diuretics. It loses potassium. Everything L loop Lasix and lose the potassium. So there will be electrolyte depletion. There will be decreased calcium, potassium, and sodium. It also increases the creatinine of the patients. So that would be for the loop diuretic. Lastly, we have the potassium. Well, there's a potassium sparing and also aldosterone receptor blockers. Example, spironolactone. So for these guys, they affect the distal tubule, and they prevent the reabsorption of sodium in exchange for potassium. So um, these are mostly indicated for patients with history of MI or myocardial infarction, and it does not. It's really contraindicated for patients with hyperkalemia and an impaired renal function. So you don't want to give that. Do not use extra potassium supplements or salt substitutes because these patients have obviously more potassium and sodium in them. For diuretics per se, it works in African American and elderly. These guys respond well to this medication. Nursing considerations, obviously, you want to monitor for the electrolyte levels, specifically your potassium, because with hypo K, going back to your fluid, to your electrolytes and fluids, hypo K can cause muscle weakness. Also, you want to check for irregular pulse, so you may want to make sure you might need to hook your patient to a monitor to watch out for hypo K. If there's hypo K, it could cause arrhythmia. um you want to watch for dehydration because you losing water, therefore you might get dehydrated if you don't check your INO and your daily weights. What else? So as I mentioned earlier, thing to remember, thiazides and the loop diuretic, letter L, they all lose K, so it can cause hypokalemia, and the potassium sparing diuretics can cause hyperkalemia. Those are two big differences. So what would we educate our patients? So you want to encourage your clients to keep all appointments with their doctor or provider to monitor for pharmacological treatments and possibly electrolyte imbalances. Again, what are those? Their hyponatremia and their hyperkalemia. If the patient is taking a potassium depleting diuretic, so obviously you want to encourage patients or clients to consume potassium rich foods such as your banana. So those are the things that you really want to remember about diuretics. Okay, so last but not the least, we have hypertensive crisis. So again, the most important stuff with this is in hypertensive crisis, the blood pressure is greater than 180 systolic and 120 diastolic. This might be a sudden thing for a client. It might be someone who has had hypertension and that's not controlled or not diagnosed, or it can be someone who has abruptly discontinued their blood pressure medications, which is why we want to talk to them about not suddenly stopping their medications for hypertension. There are two kinds of hypertensive crisis. We have hypertensive um, emergency, which is just the number I just told you earlier, systolic blood pressure more than 180 and diastolic of more than 120. They could go as high as 220 for systolic and as high as 140 for the diastolic. So with hypertensive emergency, this develops or the symptoms develop over hours to days, and you would see clinical evidence that target organ damage has already occurred. That makes this the more severe type of hypertensive crisis. So that's why it's called it is an emergent situation. The second type of hypertensive crisis is the hypertensive urgency. So on the and contrary, this develops or the symptoms develop over days to weeks. You don't even notice. But you would notice the blood pressure is getting elevated severely and it's going to be more than 180 for the systolic and same with the diastolic of 110. But the difference with this is there's no evidence of target organ damage with hypertensive urgency. So, what is our treatment for hypertensive emergencies? Our goal for these clients is to reduce their systolic blood pressure by no more than 25% within the first hour of treatment. And then, if the patient is stable, to 160 over 100 millimeter mercury within the next 2 to 6 hours, with an eventual goal of a normal controlled blood pressure within 24 to 48 hours of when treatment started. The antihypertensive medications of choice are those that have immediate onsets of action and can include intravenous drugs such as nicardipine, clavidipine, labetalol, esmolol, nitroglycerin, and nitroprusside. A lot of times in some other specific hospitals like Albany Med and St. Peter's, they use labetalol, clavidipine, and esmolol. So if you see this kinds of patient with hypertensive emergencies, well, you would see them most often. I would say you would see these patients in an ICU setup. Why? Because increased or frequent blood pressure monitoring and cardiac or heart rate should be initiated. And so if something happens, uh, the patient is already in ICU. Now, for my last slide, we're going to talk about hypertensive urgency. Remember, these patients have high blood pressure or blood pressure, systolic blood pressure of 180 over 120, and they are stable patients without target organ damage, right? I keep on mentioning that. Um, some of these patients with hypertensive urgency, they are a lot of times they are non-compliant with their with their medications. That resulted in rebound hypertension. Okay, so because they're not adherent or they're not compliant with their medications, a lot of reasons could be finances, insurances, anxiety, misunderstandings, miscommunication, some of the side effects that the medication does, and recreational drug use. So it's really important to use resources and to help them continue with their plan of care. Restarting antihypertensive medication therapy or increasing the dosage are the treatment for this medication for these patients with hypertension, I should say. So oral medications should be started from like 24 to 48 hours. A lot of times we use beta blockers such as labetalol, or these are alpha adrenergic blockers. We use as their ACEs or angiotensin converting enzyme inhibitors or captopril, and your alpha to antagonist your clonidine. Again, same thing. This requires close monitoring and blood pressure and cardiovascular monitoring. They're required during the treatment, and they're same thing. They need to be this patient's vital signs should be taken every 5 minutes. If there's any kind of changes, or every 15 to 30-minute interval for those who are stable. Again, the purpose of your hypertensive urgency is to prevent this patient to get complications with target organ or damage. So that's it for my hypertensive crisis presentation. Um, I'll see you in class.